Hi, I'm Dr. Shawn Horn. I am a licensed psychologist in Washington State, and today I want to talk to you about how my journey has unfolded in working with dissociative identity disorder. Now, before I begin, this is for educational purposes only, and I want you to be assured that I will not be addressing any of the personal stories of my clients, revealing their identity, or violating their trust or safety in any way in terms of HIPAA and so forth. So mostly I'm going to be sharing with you my journey and my experience as a clinician and how I think about DID, how I treat it, and what I've learned about the disorder over time. So when I first became a psychologist, or actually when I was in graduate school, I was working on an inpatient psychiatric unit, and that is the first time I encountered someone who I was told had dissociative identity disorder. I was very struck by this patient because they were in an alter or a part that was a child part, and it very much felt like we had this child on the adult unit, and they were very traumatized by the adult world, scared and so forth. And that experience really stood out to me. I had a lot of empathy for that experience, a lot of compassion, and just from a empathic perspective or an intuitive perspective, I did not doubt in my mind that this was truly a child I was encountering, a child part inside that person. I didn't know anything about DID at that time, really. It was briefly addressed in my graduate program. I went to George Fox University in Newberg, Oregon, which is an APA-accredited private school. As they addressed DID, they did so very objectively based on science. It was very respectful and acknowledging that that disorder is indeed a valid disorder of which people experience. What we now know is that there are as many people diagnosed with DID as there are redheads in the world. However, that's from the people that have come forth and have been properly diagnosed. I'll talk about that in a second, but we do suspect there is quite a lot more. So when I started my private practice after my internship, I had the experience of somebody coming to me and telling me that they had DID. They were referred to me and they wanted to know if I specialized in it. Well, I didn't, and I didn't know anyone who did. And so I actively sought out, due to my personal ethics and laws, that we don't deliver care in areas that we're not competent in. I actively sought out advice and guidance and somebody that I could refer this person to. And there was nobody, just nobody that I could send this person to. And this was in the early 2000s, so there wasn't telehealth, there wasn't any other option. So the only option I had was to learn as much as I could about this disorder. Well, fortunately, this person did give me a book that they were given by their previous therapist. In their experience, their therapist had identified this with them and gave him this book on the source book for dissociative identity disorder. And that was such an excellent book. It really went into detail about the difference between dissociation and DID, as well as schizophrenia and other psychotic disorders. Just real quick, for those who may not know, dissociative identity disorder was formerly named multiple personality disorder. So it has been changed in the DSM, and we now call it DID. Now, fortunately, in this experience, I just finished a course on internal family systems theory. And this course, I took that information, this internal family systems therapy that was developed by Richard Schwartz, and I incorporated it in my dissertation. So I was very aware of this concept of parts. So in internal family systems, what Richard Schwartz theory suggests is that all of us have different aspects to us or different parts to us. And we can see ourselves in those different parts. Like, for example, I have Sean the psychologist, and right now I'm talking in my psychologist voice. But when I'm Sean the friend and we're just hanging out, we're having a good time and I'm whipping it up, I might have a very different feeling to me. And when I'm Sean the mom and I'm just really being motherly to my kids, I have a different tone, a different feel. And when I'm being a neighbor, or when I am doing a hobby or I'm working out, we have these different flavors to us, different aspects of who we are, that when you encounter it, it has different feels, different tones, different ways of dressing. I dress different when I'm with my girlfriends than I am when I'm public speaking or when I am working out, of course, right? I let my family see parts of me that maybe the public doesn't get to see, about how I am when I wake up in the morning or when I'm grumpy or when I'm stressed out. And they get to see the raw, vulnerable version of me, which I might protect others from being exposed to or seeing that aspect of me, right? So we all have these different parts. Well, in this theory, he says that we have times in our life where there was feelings that we experienced, interests that we had, or aspects of who we were that was not safe when we expressed it. Something bad happened to us. So for example, let's say you cry and something bad happened. You got punished for crying. And so we take that part of us and we go, oh, it is not okay for me to cry. And as a shame specialist, this is where I bring in the shame theory, because they were shamed for crying. It's not okay to cry. If you cry, there's something wrong with you. So they take that feeling and they put it into exile. And according to this theory, we have exile parts. They're aspects of us that we really try to shove out of our conscious, and we really are invested into not seeing. Not only do we not want to see it, but we don't want other people to see it. However, it gets triggered. We get triggered. All of a sudden, our kids are crying, or a friend's crying, or a loved one, and we get this shark music, this dun-dun-dun, like agitation. And when that happens, we're motivated to do two things. We want to protect ourselves from exposure. I don't want you to see it, and I don't even want to see it. And we also want to control that feeling. So where we go then is to what he calls our fire self, our fire parts. And these are the parts that either act out or go to vices or unhealthy coping skills to manage the numbing of that experience and also the protection of that experience. So this is where we have our unhealthy coping skills like drugs, alcohol, anything that's too much, eating too much, working too much, exercising too much. But it also is some of the more problematic things, like when we yell and we get mad or we shame dump on someone. So shame dumping is where you complain to someone, hey, you didn't do this thing you said you would do. And they get really agitated and they flip it on you and say, how dare you come to me and talk to me about that after all that you've done? You know what you have done? And then they laundry list and kitchen sink you with all their complaints. So that's called shame dumping. Now, when the person finally cools off, they reflect and they go, oh, geez, see, there really is something wrong with me. And once again, it gets put into exile and we start this cycle all over again. My professor at the time, Dr. Nancy Thurston, weaved in shame psychology theory to that and called that the shame spiral. And so my dissertation was on shame-free parenting, where I addressed how we parent our children from these parts, from when our exiles get activated and when we have our fire responses to our kids, and then we shame them because we repeat the pattern. Don't cry. I can't cry. You can't cry. So we repeat the cycle. So I knew this theory. It was somewhat kind of new. It's quite the trend right now. But again, I had been exposed to this theory in 1998. So I kind of understood it. And in our class, she had us do parts work, or we had to identify different aspects of us. And when I did that, I thought about the part of me that struggled with eating, where I would eat comfort food. And then I had this inner critic that would just have shame that overeating, and you need to not do that. You shouldn't do that. And I noticed that whenever I would go around my family and specific family members, which I felt body shamed from, or that they were food police, essentially, after I would spend time with them, I would go and I would overeat almost every time. And so I identified that part, and at the time I called it honey. And that was really kind of unnerving to me. I didn't really like that. And to this day, I really don't quite like naming these parts. It's just a preference and we all have them, right? But it just felt kind of like it hit my psychological funny bone or something, you know? And so I named it honey. And I described it as she wanted to have her food and comfort herself. And when she was sad, that's what she wanted. And that there was this like really fiery protector, like a teenager that was going to fight for her right, protect honey and let her have what she wanted to have. So we did this work in the class and I found it interesting. I didn't completely connect with that because I am what they call a singleton. And singletons are somebody who has a sense of self. So with DID, we have all these different parts, right? And they don't have a sense of self, a singular sense of self. But if you're a singleton, you know that you have these different versions of you, but there's a sense of cohesiveness. Like if you see me in my mother role or in my role as a friend or as my role as a family member or at the gym or as a client in my office, you're going to have an overall sense of Dr. Sean. You're not going to think that I'm so fragmented that you don't recognize me or that I'm so incongruent. Now, sometimes we do live incongruently, where there's this Dr. Jekyll, Mr. Hyde kind of feeling where you present as this very moral, upstanding citizen, but you're secretly using drugs or having a sex addiction or something like that. And this is when people say, like, I don't even recognize you. I don't even know who you are. But even in those cases, the person would still have a sense of who they are, right? So that's a singleton. And so I'm a singleton. So to fragment my sense of self was very unnerving. I didn't really resonate with naming it, but I could acknowledge that I have different roles and different parts to who I was. So when this person came to me and started working with me, it just made intuitive sense to me that they had all these different aspects of them, these parts inside them. And what Richard Schwartz says is that our goal for therapy is to create a peaceful internal kingdom. So essentially, when you're doing parts work, you're looking at the parts of you that got fragmented or stuck or wounded, your inner children, your inner child, and you're reparenting that. And so you might have a rebel, you might have a protector, you might have a hurt part. In many ways, it's kind of like that movie Inside Out, you know, where they have the different emotions that they personified. So in some ways, I really feel that in the parts work of internal family systems, it's very much like naming an emotion that was linked to a life event. So feeling ignored or feeling betrayed or feeling controlled, like Honey, she felt unloved and controlled, right? So the teenager that would come in, according to this theory, and fight for her was the rebel, you know, feeling like I am going to have my own choices, my own personal agency. So in some ways, they can embody anger or embody sadness or so forth. So as I was working with this person, I just thought of it like that. I couldn't find anything really to guide me in the work with this person. And so I just went along with internal family systems thinking, well, this person has these different parts and each part has a different role and a different function, and they're not on the same page. And we need to create a peaceful internal kingdom. I use the example of a bus, saying that we have all these passengers on a bus and everyone's fighting to drive, and there's no order in the bus. Like the children aren't being taken care of, the bullies are out of control, the adults are getting distracted, everyone's fighting over who should drive the bus, and there's just no order. So my phone just went off. I'm going to turn off the volume here. And so that analogy really worked for us and said, let's get cooperation, internal cooperation. Again, this was just me figuring this out. I had no guidance with this. But I was clearly told that the individuals I worked with were not interested in integration. And to them, integration was like killing off aspects of them that they valued, they loved, and they needed. So what I learned over the course of my work with individuals with DID is that each part had an essential role. Perhaps it was the role to hold a memory, or to go to work, or to take care of the children that they had in their marriage, or to be married, or to go to church, or to protect themselves, or to stand up for themselves. They had all these different roles. So all of us have that in us, right? Like we assert ourselves, we set boundaries, we love, we go to work, we interact with the community. And so they essentially took each one of those experiences and personified it into this altered part. And there's different language for that. So I'm just going to call it parts. And we'll just go with that. And so, or alter. So I don't know. You get what I'm saying. So this is something that I would say is really important that I learned. We must respect the language of our DID clients. I always ask them, what do you prefer to, what word do you like to use to refer to your alters or parts? And they will tell me. And it is diverse. Everybody has different ideas of how they want that addressed. So I used to think of those dolls where you squeeze them and their eyes pop out and their ears pop out. And I had said to my clients, like, it's like these dolls, you squeeze them and those eyes pop out, but then they pop out and they create another one of those squeeze dolls. Kind of like the old movie Gremlins, that you put water and all these things would pop out of them, right? So it fragments into separateness. And because of that, they cannot wrap their mind around the concept of a singleton. And we cannot wrap our mind around the concept of a multiple or of different aspects to them. So it's really like a Twilight Zone experience. And the whole therapy journey was a Twilight Zone experience because you can't do things that you normally do in therapy. Like when somebody comes in and says, "So how was your week?" Wow, like they don't remember. So let's talk a little bit about DID, and then I'll talk about some of the challenges I experienced as a psychologist therapist working with them. And that is that this is a trauma disorder. It comes from severe trauma. Now, the trauma can be what we stereotypically consider for trauma, but it also can be other kinds of trauma, like a life, like a natural disaster or a medical problem, or like having chronic surgeries or something like that. But it's something that really devastates this child. And early on, before they have a sense of self, if this trauma occurs before they establish that sense of self, which they say around 7 to 9, I believe the current thought is 7, before the age of 7, which that's new to me, by the way. I didn't realize that they had isolated it to such a young age. But this is the current research on this and information on it or thought on it. So they don't have a sense of self, and this trauma occurs, and then they establish these different parts to them that function to get them through that trauma, to protect them by removing their awareness from it. You probably have heard those stories where someone was a victim of a crime and then they would see their body float up to the corner of the room and they would watch that crime occur. Or they were in surgery and they would see themselves above the surgery table watching the surgery. So this is disassociation. And we all disassociate. If you have ever gone into a stare, I love stares. They feel so good. Where you just zone out and you're staring. People are like, hello, right? So if you go off into a stare, that is disassociation. If you drive from point A to point B and you don't remember how you got there because you were so lost in thought and on autopilot, that is disassociation. So there's different types of disassociation. There's depersonalization, which is where I know this is my body. I know this is my hand, but it feels like I'm looking at somebody else's hand. It's a very surreal kind of experience. Or derealization, where I'm here, but it feels like I'm watching a movie. It feels like I'm not in this reality. I'm watching this reality. So there's different forms of disassociation. For the purpose of this video, we're talking about DID. So with DID, they disassociate and they lose time. This is one of the characteristics of the disorder, is that they lose time. They don't remember where they were or what was said or what happened often. So when they came into therapy and they would say, I ask them, how was your day? They don't know what to say. I mean, maybe one part would have something to say, but maybe the other part doesn't even remember what happened that day. So they're very poor, what we call very poor historians. It's very hard to get information. Sometimes I don't find out till years later about some circumstance in their life that I had no idea of, like no idea if there was children or a marriage or something like that, or they were seeing another therapist or they had another doctor. It's so hard to coordinate treatment with these individuals because you may not know all the people involved in their treatment. You're relying on their report. Now, if there are records that come with them, that is very helpful in informing you. But this is part of the challenge. The other part of the challenge is that because of the trauma, they don't feel safe. And a lot of individuals who've been diagnosed with this or who experience this have been unsafe with the medical community. They have been stereotyped, they've been stigmatized, they have been told that they don't have what they have. They've been accused of doing it on purpose, of being gamey, being manipulative, being frequent flyers at the hospital. They've been not taken seriously when they go in for medical conditions. Like they'll go in and they'll say, I'm having a heart issue. And then the doctors will look at their record and see that they have this diagnosis. And then the doctors will go, oh, they're DID, and they're dismissed. So they're not given authority or credibility. They're dismissed. They're stigmatized. And so it has not been safe for them to share this information with other providers or people. So unlike what we see in the media presents it like it's very theatrical. It's very apparent, and they will switch on command for you, and they love to show you their different parts. This has not been my experience. It is a very hidden disorder because the disorder functions to keep them safe. And because of the trauma, nothing is safe in this world. And in fact, it would be so inappropriate for a provider to say to them, trust me, I want you to feel safe with me. This is not being mindful of the trauma effect on their life. They can't do that. They can't do that. Like their brain cannot do that. Even if you want to and you choose to and you like, yes, I'm going to, not going to happen. Like your brain has learned that there is other aspects of this world that could blindside you or blindside them. So safety and trust is earned, but there's always a certain level of caution of when are you going to betray me? When are you going to leave me? So as a therapist, I don't ensure to my clients that I will never leave them or that they should feel this way with me or that I will not betray them or abandon them or anything like that. I am a human being. I'm going to make mistakes. I'm going to miss the mark. And that just is part of the picture. So it's if I really try to get them to believe that about me, I'm setting them up for another experience of abandonment and another experience of betrayal. And I don't want that to happen. So I prefer for them to say, it's good to have stranger danger. Trust is earned. Safety is earned. And I want you to be mindful of that. That's good. And especially given your history, it's very important that you know what is safe and what's not safe so we can talk about that. I think by acknowledging that by itself inspires a sense of trust between the provider and the client. The other thing is that they don't tell providers because they've been told by providers what they feel and what they think. They're not given authority to say, this is my experience. And by nature, that's just not my style. So I think in many ways, my journey with DID was very a fit with my natural clinical intuition and judgment, which I relied on heavily for the first 10 years of treating these individuals because there wasn't information out there that I have found that was consistent and made sense to me. And also a natural fit to my personal therapy style. I do respect the dignity of everybody I work with, regardless of diagnosis or age or circumstance. I also respect their right to their own choices. And I also let them be the authority of sharing their experience with me. So if I have a different impression, I will work with them on that, but we work collaboratively together. I come alongside them. I use my expertise and my training to do the best I can to help them heal and to function and live effectively and masterfully. But I am not this authority that is above them that will parent them in a directive, authoritative way and discipline them if they misbehave, so to speak. This just is not my jam. And part of that is my training as a dialectic behavioral therapist, DBT, which does hold some assumptions about therapy that clients are doing the best they can with what they have. And therapists are doing the best they can with what they have. But if therapy fails, it's not the client that fails, it's the therapy that fails and the therapist. So we see it as we either miss something or we didn't have the right strategy or something like that. So I'm very comfortable, especially also as a shame psychologist, in accepting my own imperfections and knowing that my worth and my competence is not measured by my errors necessarily. I believe that the best thing you can do is to correct your errors. So I was very open, very collaborative in my work with these individuals. I maintained a mindset of being very open and curious to what they had to say. So sometimes when they would come, I would get real familiar with one part. But down the line, all of a sudden I'd open up the door and I'd be like, hi, welcoming my client that I've seen for a long time. And they might look at me and say, oh, hello, Dr. Horn. And then I'm taken back and I think, well, like they know who I am. And then I realize, oh, they don't know who I am. Like this is a new person, a new part, essentially. So I had to learn how to adjust to that. I had to learn that I was going to have the same conversation over and over and over again, because it was like I was having a talk or teaching a concept to 20 different people or 10 different people. I learned that all of the systems, they call it systems, like it's almost like working with a family system, but it's all inside, that they have different experiences of it. So some people will report like it's like being in a room of mirrors where you have all your images behind you, and the ones that are closest together know each other, and the ones that are farther apart don't know each other. Or they're clusters, like they'll have one group that knows each other and one group, almost like separate clans. And there is common threads that there are littles, and there is adults that take care of the littles. There are an angry part. There are a scary part that may act out, hurt them, and punish them for talking. So this is something that happens too that a lot of therapists aren't aware of, is that when they take the risk to share something with us, they might get punished afterwards by a part inside them that is telling them to never speak about what happened. So it's really important that you establish safety first and that you have a plan for that to the best of your ability. And also, doing exposure work and processing can really unravel them. So I have received a lot of clients who received traditional trauma therapies, and it was disastrous. So it's really important that either you are working with someone who is trained in treating trauma and dissociative disorders, that's trauma informed. Really important. And now we have more options with being able to do telehealth, and more people are becoming aware and informed with this. So let's see, what am I missing here? So what I discovered as I was working with this population is that as I made it safe and I accepted what their story was, and I accepted all the parts, and I allowed them to share them with me and talk with me, their struggles, their frequency of going to the hospital, their self-harm, everything significantly decreased, more than any other treatment they've ever received before. So it works. And so many providers are scared, or they've been taught that this disorder was created by therapists. Quite frankly, I really have never been the first to diagnose somebody. I have received people who have either gotten that diagnosis or informed me about it. I don't suggest things. I don't tell them, well, let's see what happens. Let's see what we discover. I am really very intentional about how I ask things, how I encourage them or don't encourage them, or things like that. So really, it's very neutral territory where I'm not encouraging or discouraging, but I am being supportively open to them and learning about them. So there's a lot of harassment that therapists get, quite frankly, in treating this population. What I found was I'm constantly challenged by other providers who don't believe in this disorder. And that really is old school. Like, we need to get in the current literature on this. And there's such a difference of opinion, even in the medical field, about the best course of action to take. I lean very heavily on the international studies for dissociative and trauma disorders. I might have gotten that backwards. But there is a treatment protocol. There is treatment guidelines that are recommended and endorsed and on the American Psychological Association's site for providers. And it does support DID. It says that it's inappropriate for a provider to say to somebody, I will not speak to your other alters. I will only speak to one, and we're doing integration. This is not okay. You need somebody that will accept whatever shows up and work with that. And the current treatment that we're going for is co-consciousness. Now, some people, co-consciousness is basically where you're able to communicate effectively inside. And there's different ways that we can get them to have that peaceful internal kingdom where they're all working together on the same page and able to communicate, or create methods to be able to communicate. Some will say that they will have a part that will merge with them or integrate with them when it no longer is needed or serves. I think it's very funny when I have providers say, well, I have successfully integrated one. And I think to myself, well, which alter convinced you of that? Because the second an alter learns that you're going to shut them down and you're not open to it, they will not let you see it. They will hide it, and it will, they'll just show you only what you want to see and hear. They value the relationship and they don't want to lose it. So they'll be the good client or the good patient for that doctor so that they don't get in trouble. They don't get put on medication they don't want to be on, and so forth. So the medication they don't want to be on is some of the psychotropics, because it really does numb them out. They can't hear inside, which I've had some providers say, well, isn't that a sign that's psychosis? No, there's a big difference between psychotic symptoms and DID symptoms. And I'll make another video on that to help you understand those differences. but there are very big differences. And so I think if any of us took some of these antipsychotic meds, I mean, it's like taking this elephant tranquilizer. You just don't function. You're tired. Your brain's not working. You're numbed out from your own feelings and experiences. So they really don't like it. And they have a hard enough time talking to a doctor and reporting the effects of the medication to that doctor. So there's a lot of challenges that come with treating this population in terms of communication, of being clear about their experience and their symptoms. But what I have discovered over the course of, 18 years of working with this, that I'm delighted to know that what was natural intuition to me or clinical judgment early on in my career is now the current treatment recommendations. So there is something to be said about this parts work and internal family systems and co-consciousness. And so there is a trend moving in that direction. As providers who are courageous enough, quite frankly, to work with this, you get a lot of pushback from the community. So it's very important that we come forward and show that we are not basing this on pseudoscience. We are not wacky doctors out there. We are credible, science-based providers who are trying to do the best we can for a population that desperately needs our service and our support in a respectful way, with dignity, care, concern. As providers, it's really important to know that these individuals will come with a slew of diagnosis. This is very common with their clinical presentation. So you'll get their records and it will say they have eating disorder and they're borderline and they're ADHD and bipolar and all those things. And the reason why there are so many different diagnoses is because it's the different parts that saw that doctor that showed up. And when they show up and their behavior is really incongruent and doesn't make sense to the provider that is evaluating them, then it's perceived as gamey. It's perceived as personality disordered. So they're given histrionic or borderline or something along those lines because that's the only way we can understand it when DID is not on the radar. So that would be a flag to alert you to assess for dissociative disorders. And I'll make another video on assessing that, but there are there are measures that we use now to help us identify dissociative disorders. It's not enough to give an MMPI or to just do the basic evaluations that are being given in psychological settings or hospital settings. So I will say that the other thing is, this is not entertainment, folks. This is not how it is in the movies. And if you're a provider and you want to work with this population because you find it entertaining or you just want to be able to say you work with this is not the motivation that's appropriate. And I would say check yourself. Check yourself, because really this needs to be a passion to be used as an instrument, as a service to improve the life of these individuals who are suffering, who are not understood, who are rejected, stigmatized, blamed, shamed, and severely traumatized. So it is sacred groundwork. It is sacred ground work. Be mindful of that. And be mindful that if they get mad at you or you disappoint them or something, that it's a trauma brain. There's a trauma brain there. And so we cannot take it personal or get angry back or defensive, but really try to understand, how is it possible this person is having this experience right now? Or how is it that they're so scared? And really connect in a safe, therapeutic way. You don't have to hash through the trauma. You don't have to go through the details. This is what the new research is showing us with trauma work. with the polyvagal stuff and all the current literature out there right now on trauma is that we don't have to dive deep like we once did. And so there are other options of treating trauma than having to reprocess and go through all of that again. So I am so grateful for every client that has given me the opportunity to work with them, to allow me in to do this sacred work and to be my greatest teachers. Because truly, after being in the mental health field for 28 years and coming in on this during a time where there was not a lot of research on it, they did teach me everything I knew. And one last thing I would say is that as a provider, when I have observed their switching is when one alter goes back, another one comes forward or fronts. It's very subtle. You can't really tell. They get a very tired look on their face, or they might look away or have some distraction body language that they do. And so you can't always tell. I happen to yawn every time they switch. It's a phenomenon that I have. My brain thinks they're yawning. So that has been some biofeedback that's helped me to be able to know when things are switching. So I would love to know what your thoughts are. If I have said anything that you are in disagreement about, or you want to challenge or add to, please do in the comments. I am delighted to announce that I am part of a conference that is coming up this November in San Francisco for Dissociative Identity Disorder. It's being put on by Toi Magazine, and we have many speakers who have been advocates for the DID community, including dissociated, entropy system, multiple and me, fragmented. I'm still learning all these terms. So I'm going to review the speakers again. It's fragmented psych, multiplicity and me, the entropy system, disassociated, did I say the labyrinth system? Yes. And Toi Magazine. So those are the speakers. And these individuals have been diagnosed with DID, and they are mental health warriors out there educating the public and others about DID. And they're doing a phenomenal job. I cannot recommend them highly enough. And I really think that out of all the trainings I've gone to and books I've read, they are so research-based and informative that we as providers can get continuing education from these folks. So check it out, and check out Toi Magazine's conference. It's called Entitled to Life, a conference in Gala Dinner. It's going to be November 6th through the 7th in San Francisco. And I will be one of the speakers there. And we're going to have other providers there as well who are DID informed. And it's just absolutely going to be amazing. So go to the link below to get more information. If you have DID, or you're a loved one or provider a loved one of someone diagnosed with this, or a provider who works with this, I think this conference would be of interest to you. The focus of the conference is really to break the stigma, and also to show that you can have a life and do well, that this diagnosis does not define your destiny. It does not define you or yous, so to speak. And I would say that every individual I've worked with, or most of them, have been very successful in functioning in the world beyond what most would think and what they stigmatize. And they have jobs. They never miss appointments. They're so responsible with their finances. They always pay. I would say out of all my clients, this one population exclusively have not missed appointments or messed up their bills. So they're very responsible. And so that's what I have to say about that. So thank you so much for watching this. Please subscribe and share, and watch for more information on DID. I'm going to step up and begin to address this topic as a provider who is an ally to individuals with DID. We are out there. We exist. So thanks, everyone. See you next time. Hi, my friends. Thanks again so much for joining me today. I can't wait to bring you more content in the future. So please make sure you subscribe, like, follow, comment, and let me know if there's anything else you want me to talk about. Also, come on over to Instagram and join me over there. But whatever you do, make sure you come over to my website and sign up on my email list so you can get the newest and latest updates about some cool stuff I have coming ahead. So thanks again and have a fantastic day. And remember, you are amazing.